Good evening, everybody. I'm really delighted to be here this evening and welcome you to the very first, the inaugural webinar for the Race and Health Observatory. You will have heard a lot about the Race and Health Observatory, and you'll hear a little bit more a little bit later on. My name is Yvonne Coghill, and I have been around in the NHS for a very, very long time. I recently retired and I'm now working as a race advisor for the Race and Health Observatory. The reason we are here is because we have had a dreadful, dreadful year. The statistics are out there, but actually what we're talking about is over 115,000 people that have lost their lives to this dreadful and awful disease. And it's not just about the data, is it? It's about the fact that these individuals, these people, are people's grandparents, their parents, their brothers, their sisters, their aunties, their uncles. You know, mothers and fathers and children have lost their loved ones, and it's horrendous. And more than that, we have lost quite a few people in our NHS, the doctors and nurses that work tirelessly to make sure that things stack up for everybody within our NHS and within our country. So from that perspective, I think we need to never forget those individuals. The reason why we are here this evening is because we know that there have been real difficulties and problems with the disease itself and actually the vaccine. There's been a lot of coverage about the vaccine. There's been a lot of coverage about the disease itself. And actually, I think that people are a bit turned off now with listening to the news about COVID, fed up with the lockdown and fed up with everything else that we've got to deal with. Last night I was listening to the TV and I heard the Deputy Chief Medical Officer who was on TV, and he said something that I thought was really curious. He said that the virus does not discriminate. And I listened to it, and I listened to it a couple of times, and I thought to myself, well, actually, what we know is that the virus actually does impact on some people more than it impacts on others. And we know that people from Black, Asian and minority ethnic backgrounds are much more likely to succumb to this virus than their white counterparts. So in a sense, the virus does discriminate. So we know that people from various backgrounds have been disproportionately affected by this virus. And so what we need to think about, what we need to do is to be able to help support people, not just people from Black, Asian and minority backgrounds, but everybody, but particularly people who are more susceptible to COVID-19 and more likely to die from the virus. So tonight, what we've got are some of the best minds, I think, in the country around this agenda. People who you will know. I think they need no introduction, but I will do very, very quick introductions of who we have here tonight. We have Dr. Malarasan Hanva, who is a consultant medical virologist and is working at the King's College in London. He is very well known and has been doing a lot of work around COVID testing and so on. We also have Dr. Chand Nagpal. I've known Chand for many years, and I actually have known Chand longer than I've known anybody else on that panel. Chand and I used to work together back in Harrow when he was chair of Harrow East PCG, and I was locality manager in Harrow West. So it's brilliant to actually work with Chand these days and to see him. Similarly, I've known Dame Donna Kinnair for a very, very long time. When I started in working at the Department of Health, Donna is well known to everybody. She is a phenomenal woman, a wonderful nurse. She has fought tirelessly throughout this pandemic for nurses to keep them protected, to keep them safe. And I'm delighted that she's here with us today. We also have Professor Jackie Dunkley-Bent, again, somebody who needs no introduction. She's our chief midwife, Jackie has been working in the system for a very, very long time. She's well known, well liked, well respected, and again, somebody who has been working tirelessly throughout this pandemic to make sure that mothers, babies, and everybody else that comes into her sphere is kept safe and well. Next, we have Dr. Naqvi, and I don't know what to say about Habib apart from he is my friend. He is loyal, he is supportive, he is somebody who understands and knows what he needs to do in order to help Black, Asian and minority ethnic people get the very, very, very best out of the NHS. And I think he is absolutely the right person to be leading the Race and Health Observatory. And last but not least, we have Professor Kevin Fenton, who again needs no introduction. And I am really very fortunate because these people are not only massive inspirations to me, but they're all very, very good, loyal and true friends. So I'm really delighted to have them here with me tonight. And I think without further ado, we can try the survey a little bit later on and see if that works. But without further ado, I think we'll go straight into the talks, and we will hear from Dr. Malo Sudhanva about the actual virus itself. So over to you, Malo. Thank you.
Thank you very much, Yvonne. It's an honor and pleasure to be with you today. So here are my slides. I'm just going to present straight away. So that's me, consultant virologist at King's and a few other things. So number of jobs is proportionate to number of slides that I have. So moving on quickly, I'm going to have a laser-like focus on the virus, the vaccine and the myths. So the reason why I had to show the virus is because I'm a virologist, and this is the one we are worried about. This is the spike protein, as you can see there. And that's what we are going to focus on. Most of the mutations are on that, and that's where most of the problems are. So here's a simple thing. I'm not going to go into details of this. This is a virus, and it enters this human being through the receptors, the ACE2 receptors, when the spike proteins actually attach. And once the virus comes in, then it acts, that RNA there acts as if it can start generating the mRNA, which leads to the proteins, and that leads to the virus coming out. The reason why I'm showing you this is these are the points which will be discussed in my talk. For example, mRNA for mRNA vaccines and the receptor binding protein. That's where you have the S protein. That's where we have various mutations. So this green book, which is immunization against infectious diseases, is where most of the details are there within UK, where we have collected on COVID-19. It is a very comprehensive one, and that's what we use. So here I want to just show you one important thing: the mortality infection fatality ratio between the 65 and 74 year olds is about 3.1. But once it crosses 75, it goes to 11.6, and that's why the care homes and nursing homes we are worried about on all the mortalities. So the virus variants, you have the UK variant, which started in Kent in around September, identified November, December, B1117. So this one has 23 mutations, of which 2 are deletions and 2 are substitutions. And we saw this in Milton Keynes first, and between December of last year and beginning to end, it moved from 55% of all positives to 98%. It's a lot more transmissible, that's why I call it more sticky and quite more severe disease, according to initial nerve tag reports that was announced by CSO, where the mortality is 13 per 1,000, whereas the old virus is 10 per 1,000. Now this virus has replaced the old one completely, almost in almost all areas. However, we do have these variants. This is the Kent variant, and this is the South African variant, which you hear in the news. This is the Brazil variant, and this is a Japanese one. And these two are variants within the Kent variant, which has got E484 mutations, which are seen in Liverpool and Bristol, and those are also being investigated. So the South African variant is where you have the stealth mutations. The most important thing here is this E484K and K4179. Higher viral load, increased transmission, and there is potential vaccine efficacy issues, which I'll come to later on. The Brazilian variant, unfortunately, there are not many sequences available, which whatever we have that are available, we know these are the mutations that are there. So the Pfizer announced the Pfizer vaccine does neutralize these variants, the South African variant and also the Kent variant. The AstraZeneca did vaccine which was used in South Africa. There was a very small trial, just under 2,000 people, young adults, and the endpoint was mild symptoms and did not make any difference. And later on, a couple of more slides where I show you in this particular slide, this is a South African variant where there are 3 vaccine trials where they've shown partial resistance, whereas with the Kent variant, you have the partial vaccine efficacy for the Novavax and AstraZeneca. There is a decrease from 85 to 75. Still, it is good. And this is for the pure virologist, how all the mutations that are there summarized in this slide. So now comes the philosophical question. What is the possible future of this virus? Way back in 1890, there was an outbreak amongst human beings. They all thought it's flu. Actually, before that, there were an outbreak of the virus in some cows, and that was way back in 1890. And we knew that using the molecular clock, they looked at both the cow and the bovine OC43, which are also coronaviruses, and they traced it back to that particular massive outbreak that happened way back in 1890. So now what does this virus cause? This causes 10 to 30% of common cold. So what it means is the SARS-CoV-2 virus that we have now is here to stay. So we need to live with it this year, next decade, in the next 40, 50 years, or even more. So that means there's a balance between the viruses and the humans. All we have amongst the humans right now is the vaccine and, of course, all the social distancing measures that we have and the treatment. So it's a constant battle. We want this virus to become common cold eventually for everyone, and that's the aim. So going straight on to the next topic, which is the vaccines. So these are the vaccines, the mRNA vaccines, the adenovirus vector vaccines, the protein-based units, and the inactivated ones. So you have the phase 2 and the phase 3 trials. The phase 3 trials, this is the list of various trials that are happening. So I won't go into the details of the types of vaccines, except to mention that inactivated vaccines are coming our way. And the subunit vaccine, the Novavax, has got a lot of potential. And of course, the viral vector-based vaccine is the Oxford AstraZeneca vaccine. The mRNA vaccine, you're all familiar with the Pfizer and the Moderna vaccine, and these are the mRNA vaccines. So that's the mRNA. Going back to my original diagram, that's the mRNA. And in the humans, we have the DNA, which leads to mRNA, which leads to the protein formation. In the viruses, the virally derived self-amplifying RNA serves as mRNA by itself, and that's what this is. Whereas the vaccines just have the mRNA, so you can produce the exact proteins. And because this mRNA is very labile, so they are enclosed within this kind of PEG nanoparticle, and they're stored at -20 to -80 degrees Celsius. So let's look at the difference between the Pfizer and the Oxford vaccine. The Oxford vaccine, however, has got the DNA which is encoded within the adenoviruses, the common cold chimpanzees, and then the mRNA, which I mentioned to you, and can actually encode for the S protein, just like the DNA of the Oxford vaccine. And this is the DNA of the Oxford vaccine that goes into the human being, and that's your RNA of the virus spike that goes into the human being. Once the Oxford vaccine goes in, that DNA is, basically is available, and you have the production of the S proteins like that. And the mRNA vaccine, however, directly produces the proteins via the translation, and that is released by the cells. This is inside the human body in the muscle. So the endpoint of both these vaccines is production of the spike proteins, which are seen by the dendritic cells, which is taken to the lymphatic system, and then everything is the same. Now the similarities, both the B cells and the T cells are important. The B cells produce the antibodies, and the T cells produce the T cell based immunity. So Novavax is similar, where you have the baculovirus vector, and again everything is the same. Then you have the spike which are produced, and these are packaged into soap bark material, and these form nanoparticles, and they activate the T cells and the B cells. Similarly, Covaxin is an inactivated virus, and that is engulfed by the cell, and that is that protein, spike protein, is produced, and again you have the T cells and the B cells. So on 2nd of December, JCVI for UK, they looked at all this data which is coming in real lifetime as the studies were happening way back in April, May, June, July, August, September. And then they finally said, for the first, the priorities, they did all these priorities, number 1, 2, 3, 4, 5. And this is the and they use this criteria, and also this extremely vulnerable criteria, which is all these people with organ transplants or specific cancers, etc., etc. These are all again in the green book, which I mentioned to you earlier. So here's the Pfizer versus BioNTech to show the efficacy. The vaccine is in red and the controls are in blue. As you can see, within day 10 or by day 10, you start seeing a divergence, and that's your vaccine, and that's your controls who have not been vaccinated. And this black, the dots here are the severe cases. So vaccine efficacy here is 94.8. So the vaccine efficacy was good, both in people who had a lot of, there's no discrimination between the asthmatic, the people who have COPD or diabetes or hypertension. These are the high risk, which I'm sure other speakers will touch upon. Single dose issue is something the UK advised, with everybody opposed in the world, but now everyone is coming around, and this is the data on that to show the vaccine efficacy following a single dose after 28 days was 91%. And again, the Pfizer versus BioNTech, here the colors are reversed. Here you have the after a single dose, that's your vaccine and that's your control arm. Again, it's where you can see the clear divergence. So there are some more questions. Interesting story here is some pregnant women, some women became pregnant after getting the Pfizer vaccine, 12 of them, and they went on to have normal babies, no problems. So that will come our way eventually. And also there have been studies in the last couple of weeks where the cord blood has antibodies following vaccination. So in a pregnant woman who's delivered. So going straight to the Oxford AstraZeneca, I mentioned to you about the chimpanzee adenovirus as a vector and then leads to a spike protein. The efficacy varies between 60 to 90, and that's your COVID-19 cases. It prevents in 70.42%, whereas after one dose, it prevents in 52%. And then a recent study which came up, which was which showed that this is the antibody production after 28 days is fairly high. As you can see here, 28 days after the dose, after 12 weeks, it goes up to 8618, as you can see, very quite high. And this is our T cell response, which shows clearly that T cell response following the other spot, it stays after the first dose and it remains the same even after second dose. That means one dose is enough for a while. And that's again been published. This is a preprint that's just come out in the last few days to show that after one dose, symptomatic cases, 20 to 90 days, 76% efficacy, and any PCR positive result, you got an efficacy of 67%. Moderna is another mRNA vaccine. I won't go into the mechanics of it, similar to the Pfizer vaccine, and that again, you can see the clear divergence of the placebo versus the vaccine arm and the vaccine efficacy there. So who has the biggest vaccine portfolios in the world? Of course, it's the UK. I think we are lucky that we are here in UK, that we have the maximum number of vaccine contracts. And within Israel, in the last few days, this has come out where they looked at the population of people who were more than 60 years of age, who had a better coverage because that's where they were prioritized over the 0 to 59 years. You can see new cases after 28 days, minus 43%. That means 43% fall. Mild to moderate cases, 32% fall, 24% fall in severe, and 19% fall in the very severe again. So what you have is a population which is not vaccinated. As you can see, even the younger ones, actually there is an increase, whereas in the vaccinated, there is a decrease. So here's a summary of what exactly happens in these vaccine trials. And this vaccine trials, this is considerable detail here. Sorry for this, but just to show you, these vaccine trials had the Black and Afro-Caribbean in various percentages, 9.3, 10.2, 4.4, reflecting the communities where they were trusted. Same with the Asian, you have 4.5, 4.6, and 4.6 in the trial. And in all of them, efficacies were okay, as you can see, same as any other population. All the rest of the population. And then in the elderly also, you had the efficacy at 94.6 in the Pfizer and 100% after 75, 86.4. And then again in the elderly here in the AstraZeneca, you have 5.9%, and those two were at 100%. So we have various studies that have come through. And now straight onto the side effects. Side effects are all mild. As you can see, it appears 1 to 2 days after the vaccine. In the Pfizer, it's second dose after first dose, second dose after first dose in Moderna, whereas in the AstraZeneca, second dose less than the first dose. That's what happens in AstraZeneca. And the severe side effect is very, very rare, 1 to 2 per 100,000. And these are all very, very rare. And we need to take that into context. This is a side effect of the vaccine, which are very, very rare. Compare that to what happened, the global situation. 106 million cases in the world, 2.3 million have been have deceased. So that is really sad. So No, is a message for you. The virus is here to stay, so take the vaccine. The morbidity and long COVID, which I'm not touching upon, long COVID are the side effects of the actual getting the COVID, so take the vaccine. Mortality from the COVID is there, so you got to take the vaccine. The vaccines are safer than getting COVID. Vaccine efficacy prevents severe COVID. Vaccine protects you and people around you from severe COVID. Overall community benefits are enormous, and vaccinated versus unvaccinated nation, there is going to be a dichotomy. I expect a lot of political wrangling over that, and social and economic differences will emerge between the vaccinated and unvaccinated communities and nation. And then very soon there are going to be vaccine passports of some sort. I can't predict that will come for travelers. So if you want to have a holiday, take a vaccine. So going straight on to some myths. So these are myths that are wrong. Vaccine causes COVID. That's wrong. You probably are incubating the virus, and then you go and take the vaccine. Within 3-4 days, you get it. Vaccine has serious side effects for everyone, which I proved to you earlier. Vaccine has pork products, it doesn't have. Vaccine has beef products, vaccine has alcohol, it doesn't have. Vaccines are not to be given to anyone with any allergy. That's wrong. Quite a number of times the allergy classification is very wrong. So then everything on WhatsApp and Facebook, which is true. If you all act as dead ends to all WhatsApp messages that come our way and not forwarded to anybody else, I think the world will be a safer place. The mortality of COVID is less than 1%. Why should I take the vaccine? That means that 1% that you can't pass on the virus to someone else, and that's why you got to take the vaccine. With all these new variants, what is the point of vaccination? Because with every new variant, the world is going to produce, the scientists are going to produce new vaccines. So you got to take the vaccine this year, the next year, the year after, 5 years down the line, 10 years down the line, because the virus is here to stay and this is your defense. You got to take the vaccine. The vaccines were approved too quickly. That's so wrong, because there are a number of hours of vaccine, number of man hours that have been followed is quite enormous. People were very, very efficient, and that's how it is. And my last slide show PCR will be positive for mRNA vaccine. That doesn't happen. I had COVID, so I do not need vaccine. That's not right, because you have reinfection rate. Once you have COVID vaccine, you're immune for life. No, we can't predict that. Probably 6 months, 1 year, maybe we don't know. Vaccine mRNA damages human DNA. It doesn't. It cannot integrate. I cannot get pregnant immediately after vaccination. That's not true. Eventually, there may be some rules. Governments are not producing those policies. Pregnant women probably will get the vaccine routinely, just like influenza vaccine. You can ditch the mask after vaccine. That's not true, because you can still transmit the virus. And I'll follow on last to share. In my slides, I focused on the public communication, just on the myth busting and clear rationale for prioritization. Thank you very much, and I'm ready for question and answers.
Wow. What can I say? That was a quick whip through, but I'll tell you what I got from that. I got that there has been a lot of work put into the vaccines. I got that you should take the vaccine. I got that there is good efficacy for people from Black, Asian, minority ethnic backgrounds. I got that side effects were rare. You get some, but not really big ones and serious ones. We have a couple of questions for you, Malheur. So let me ask you this. Somebody's asked, is it possible that even though the vaccine may be effective in dealing with COVID-19, could it in some way cause any long-term implications to our bodies in any way, in particularly if we've got underlying health conditions? Has this been trialed in people that have got long-term conditions?
Some of the people who are on phase 1 are already like 6 months, 7 months down the line. So now you have to remember the mRNA vaccine, for example, just to give an example, it goes into the muscle and it's very labile. It's so labile, it has to be packaged in a lipid molecule and then stored at -20, -70, 80 degrees. That means once it gets into the body, it starts getting destroyed. So in the muscle, it's destroyed very, very quickly. It does its job. It's destroyed very quickly. It takes up and regenerate itself, so it doesn't last. And all the vaccine excipients have all been the excipients which have been used in other vaccines before. So based on both these things, it's not, and even the follow-up, nothing has happened. So I would say, do I want long COVID or do I want to remember a nice vaccine dose 6 months ago, 1 year ago? I would prefer the vaccine.
Indeed. And then there's another question about lupus. It says, I have lupus. Is it safe because of the side effects that it could possibly accrue? Will it be a problem for me?
I'm not a specialist in lupus, but you need to tell your physician to look at the Green Book and the JCVI chapters where it clearly says, and the immunosuppressed people eventually if you are extremely vulnerable, vaccination is desired, not just for yourself, it's for your family around you also. It's like a ring vaccination. That's what used to happen for smallpox. So ring vaccination, similar things. I would go with your physician's advice because we don't know what kind of drugs you're on.
No, I totally understand and agree with that, because I believe, I mean, this webinar isn't about trying to make people take the vaccine. This is about giving people the information that they need so that they can make the decisions themselves about what works for them and what doesn't work for them. Because, you know, there's a lot of things on social media. You know, when I was growing up, there was no such thing as social media, but now everybody has a smartphone and they're hearing all sorts of things. And what we know is that people from Black, Asian and minority ethnic backgrounds are much more hesitant. There's more vaccine hesitancy as far as they're concerned. And what we're trying to do tonight is to get them to hear the facts as you've laid them out quickly, but beautifully, because there isn't as much time as we would like to hear in depth and detail. But of course, if people want to, they can send questions in. And of course, I'm sure you will be happy to answer their questions for them. Thank you very much. There's a couple more questions, but I think those questions will be better answered by other people because they're asking things about data collection and so on and so forth. So can I just thank you so much for your wonderful presentation? I really, really appreciate it. It gave us some really very clear messages about the vaccine and about COVID. So thank you. And without further ado, we're going to go to Dr. Chand Nagpal, who is the chair of the BMA. Chand.
Good evening to everyone. I'm really delighted we're having this very first webinar of the Race Observatory. So I'm chair of the British Medical Association Council. We represent over 160,000 doctors across the UK. And what I'm going to be talking about is the BMA's experience of representing, supporting doctors throughout the pandemic. There's been a lot of, obviously, a lot of attention paid to the inequalities that have surfaced through COVID-19. But I just want to remind ourselves that in terms of the medical profession, there has been significant race equality that predated the pandemic. With regards to doctors, there's been a very historic level of differential attainment, meaning that doctors from a BA/ME background do less well in passing postgraduate exams. A lot of research has shown this is not related to lack of ability, but it's much more to do with lack of support, lack of inclusion that affects the ability for doctors to perform well and be their very best. That has led to an NHS where there is unequal career progression. If you're a doctor from a BA/ME background, you're less likely to be offered a consultant post, less likely if you're shortlisted to be given the job. You have more BA/ME doctors in a grade below a consultant post called the SAS grade. You also have an ethnicity pay gap in the NHS in terms of doctors and healthcare workers more widely. And we've also seen an increase in racist abuse against NHS staff. So I think this is of relevance when we start looking at some of the phenomena and the exacerbation of these inequalities during the pandemic. Next slide, please. And the other thing that we've known about in the BMA is the unequal culture that has affected and been quite disturbing in terms of the impact on our BA/ME doctors. Back in 2018, we conducted a very large-scale survey as part of a project that I led that showed that doctors from an ethnic minority background were about twice as likely not to feel confident to raise concerns in their workplace, whether it was a patient safety concern or about a concern about the way they were treated. They were less able to speak out. And the reason they said they were less able was because they felt if they did speak out, there would be adverse consequences, recrimination, or worse, that they would feel blamed for the very issue that they were complaining about. We also know that BA/ME doctors have said to us that they feel less included in their workplace. They also sadly experience bullying and harassment at twice the rate of their white colleagues. And we also know that BA/ME doctors are referred for disciplinary processes to the General Medical Council at twice the rate of their white colleagues. And research looking into this does suggest that these are workplace biases that work against ethnic minority doctors. And we, some research last year from the General Medical Council, actually 2 years ago, has shown that we know that when you are suffering bullying and harassment, when you're being treated unequally, unfairly, it affects your mental state, and that affects your clinical performance, and that in part will, of course, increase your risks of medical errors. So it's a vicious cycle that we have a very negative culture in the NHS and have had, unfortunately, for far too long. Next slide. So when we then look at what happened during the pandemic, back in April, in fact, in early April, it was quite alarming for me and representing doctors and for the medical profession, that the first 10 doctors who died from COVID were all from a Black ethnic minority background. I mean, that's staggering. 100% of doctors who had died were from an ethnic minority background. And that led me to call this out on behalf of the BMA. We were the very first organisation to be highlighting this in the media in a Guardian interview that I had, and thereafter I'm very pleased that this became obviously an issue for all of society and so many other representative organisations, and we did then secure a review from Public Health England, from the government, that it commissioned literally the next week. But we also found that this was affecting healthcare workers widely, not of course just doctors. About 2/3 of all healthcare workers who've died have come from a BAME background, large numbers who've come from overseas, even though the overall proportion of healthcare staff in the NHS is about 21%. We then found that this was affecting the community at large, where in fact 4 times as many people from an black African background had died from the virus, and about 3 times as many Pakistanis, Bangladeshis. So this was having a real impact, and as a doctor, this was affecting the community that I serve as a GP, but also differences between the different ethnicities. And I'm very pleased that we did have an excellent report, and you'll be hearing from Kevin Fenton later. I have to say, if there was one thing the government should do, is implement that review to its letter, because it does give us some very clear ways forward. And the BMA has, and on behalf of the doctors I represent, we have at every stage highlighted these issues, and that the need not just to conduct a review, but right from the outset, we said back in April that we needed to put in place mitigations, risk assessments. So it's not just about looking at reasons why, but we needed to protect healthcare workers in real time. And I've advocated for this, not just for healthcare workers, but for care staff and all of the key essential workers who've been exposed to the virus, from taxi drivers through to public transport, to those on supermarket tills. There has been a real issue around our BAME communities not being protected. Next slide, please. Now, one of the things we did throughout the pandemic is some tracker surveys. We have been doing, we've actually had 11 surveys throughout the pandemic from April that has given us a real understanding of the impact of COVID-19 on our doctors. And 16,000 responses in 48 hours. So real good representative responses. What they've shown throughout is that the experience of BAME doctors has been far worse. They've experienced additional pressures in every single survey we've done. So when we had the height of the first peak, when there were shortages of PPE, BAME doctors were 2.5 times more likely to report not feeling protected at work compared to their white counterparts. Next slide, please. So when we look at inadequate PPE during the first peak, even in the most highly contagious settings, what we call AGP settings, where the virus can be transmitted through fine aerosol spreads, 39% of BAME doctors, compared to 90% of their white colleagues, said they did not feel adequately protected, and that they were feeling pressured to work in spite of not being protected. In fact, what the BMA did in April is we've set up a 24-hour member helpline, because we knew that doctors would want to call us at all hours, maybe 2 o'clock in the morning, saying that, what do I do if I'm being asked to go into a ward where I don't have the right protection? You know, what support can I have? So that's the support we needed to provide our doctors. In fact, even in October, this is after the first peak, we were still finding that BAME doctors were telling us they were really concerned, continuing to feel concerned about PPE shortages. and that when you look at fit testing, we've had greater numbers of BAME doctors telling us they've not been confident and supported in having proper fit testing. And for those of you who may not know, these are masks that need to be tightly fitted in highly contagious areas such as intensive care, and they only work if they've got a proper seal. And many doctors felt that they were pressurized to continue working without proper fit testing. Even in December, just literally 2 months ago, we continue to see BAME doctors telling us they do not feel properly protected compared to their white colleagues. So these are surveys that really do tell a very clear picture. Next slide, please. Now, this culture of bullying I told you about at the beginning that predated the COVID pandemic just became far worse during the pandemic. So here we had doctors afraid to speak out about PP shortages. 3 times as many ethnic minority doctors were afraid to speak out. And they said the reason they were afraid to speak out was because they felt that there would be recrimination, adverse consequences, that in fact it would affect their career progression. That's the reasons why they didn't speak out about really a risk to their own lives. During the pandemic, they were more than twice as likely to experience bullying and harassment by non-clinical managers, but also by their own clinical colleagues. And this is really, in addition to all the harrowing experience of being a doctor working in a pandemic, this is the additional pressures that BAME doctors have faced. Next slide. And this is depicted from a case of Dr. Peter Tunn, who was a very well-known BAME, British Medical Association colleague in the north of England. And he was a specialist working in a hospital, in fact, not in the north, in the south of England, Royal Berkshire Hospital. And I spoke to his son after. He was one of the unfortunate victims of the pandemic, one of our own colleagues who died early on, and his case was quite well publicized, so there's nothing I'm saying that's confidential. And I spoke to his son, and this story is as I've said, well known, where he was working back in, I think it was April or March, it was March, sorry, in a non-COVID ward. And he knew, like we all knew, that patients could easily be carrying the virus in an environment where it was spreading between wards and between different patients. We knew that. And he asked to be able to be wearing a face mask, hardly a big ask. But the policy at the time was that you only needed face masks in COVID wards. And he explained that this was clearly not an appropriate way to protect colleagues. And he was refused the face mask. Literally, and this was a non-COVID ward. I think a few days later, 4 patients contracted COVID on this ward. A week later, he got COVID. And I think just a few weeks later, not only was he on a ventilator, he died. And when you actually then look at the emails he sent out, pleading emails, he accepted it. He accepted the authority telling him he couldn't have a mask. And I think what I'm trying to say is, I think you can't divorce this sort of example from what I've described before about a culture of fear, a culture where you don't feel able to speak out because you're afraid of authority affecting your career. And this is a tragic example. I mean, it's painful when I spoke to his son, but I think it highlights in reality what these statistics amount to. Next slide. Now, we've also found that that BAME doctors haven't been supported in terms of their actual work on a day-to-day basis. They were less likely to say they had been able to take full breaks. They were twice as likely to say they'd had to cancel leave during the first wave. They have reported anxiety, depression and other mental health impairments at a higher level than their white counterparts. And they've also reported being less able to access wellbeing support. And remember, all of our surveys are being sent out to doctors equally. And so these are not sort of self-selected responses. This is what we're getting in real time. Next slide. So risk assessments, we knew right at the beginning that this wasn't just about doing a review about why doctors from a BAME background were getting ill and dying. We asked, and I wrote to Simon Stevens, Chief Executive of NHS England, back in early April saying we need the review, but more importantly, we need to put in place mitigations, protections for our doctors who are at high risk, and we need to create a risk assessment tool. In fact, I think I wrote 3 different times, and eventually the risk assessments were introduced in the NHS. And we went further at the BMA. We wrote to every single hospital trust to say to them, what are you doing? Are you risk assessing your doctors? You need to be protecting those at highest risks. We even, in fact, produced through our Medical Academics Committee in the BMA our own best practice risk assessment tool, so that doctors themselves could assess whether they were at high risk and really, call upon being protected if they fell into that category. And we were calling for doctors to be able to be redeployed in non-COVID areas, work remotely. There was plenty of work for doctors to do. It's not about stopping work. We also called for occupational health assessments for those in general practice and primary care, because you don't actually have the same system of occupational support within the community. And next slide, please. Now, although we did find that by June, July, doctors had been risk assessed. Remember, risk assessment is not an end in itself. It's not a tick box exercise. It's what happens when you're risk assessed. Have you been given adjustments? Have you been given other ways of working to protect you? And again, BME doctors were twice as likely to say they weren't satisfied with their risk assessment, and also that they had not had the right adjustments made after being risk assessed. So I think it's really important not to think of this as a tick box exercise. I think a lot, again, relates to what I said earlier about the culture, about doctors not feeling as able to challenge, to really speak out. And even in December, just literally 2 months ago, BAME doctors were twice as likely to say that when they had been risk assessed, they felt that they needed updating to really adjust for their current needs. One of the big issues at the moment is around enhanced PPE, that we are still using guidance based in last April, when we actually have a much more virulent strain, but also airborne spread that has become much more evident. Next slide. When it came to the vaccination program, again, we knew and we called for back in early December, and I wrote to, again, NHS saying we have to have an approach that systematically vaccinates those healthcare workers that are at highest risk. And so when we did get the vaccination program, our own surveys had shown that, in fact, that didn't happen. That in fact there was no prioritization in a systematic way. We called for every single healthcare worker to have received their first vaccine by the 31st of January. I'm pleased that has happened for doctors, but I'm actually quite distressed that certainly has not been the case for nurses, especially those in the community, has not been the case for porters, ancillary staff, and care workers. So there's I speak for doctors, but actually I'm speaking for healthcare workers, because we're all actually part of one family of carers in our health and social care system. So anything I say, I feel equally distressed if it's not as equal for any other healthcare worker. We carried out bi-weekly surveys of doctors, and in fact the other thing that we did was we were featured and that's the picture of me on the right, in a whole Newsnight feature on the vaccination program and healthcare workers, which really has highlighted that we should have learned from last April to June, and we should have taken a systematic approach to vaccinations, but that didn't quite happen. Next slide, please. So now looking at the second dose, we do need to make sure that those at highest risk really are prioritized. We must make sure that all healthcare workers are vaccinated and get their first dose. And this needs to be done really yesterday, but it really is an absolute priority that we shouldn't continue to have our high risk staff at risk. The other issue that I want to raise is that we also at the BMA have been calling for prioritizing and tackling those high-risk people in the community who are in deprived communities and high-risk BAME staff who don't fit neatly into the JCVI first 4 tiers. The taxi driver who may be in his mid-60s with diabetes, who may be in an overcrowded house, exposed to the virus, will not fit currently in a JCVI priority, but will be at high risk. And we know that the mortality rates in deprived communities is twice as high. There is some flexibility in the JCVI guidance that allows for this, and what we're pushing is for that flexibility to become a reality. So that's another issue, and that's the Guardian interview that I had on this very matter. Next slide. We've at the BMA, we've now, as a result of last year's experience, we have now set up national BAME networks in all of the UK, and we have a national BAME forum, really because there was a calling amongst our BAME doctors that they felt they needed voice, they needed advocacy, they needed to actually be seen and heard, and we want to provide them with that support, that confidence that actually they cannot and must not be treated unequally. We also want to make sure that they have a voice in influencing local and healthcare policy at a local and national level, but also really important, and I think this must come through in all of the unequal experience, is to celebrate and the contribution that BAME doctors and other healthcare workers have and continue to provide in our health service. This is also about something positive, and that's what the pandemic has shown. The nation would have just not survived if it hadn't been for the contribution of all the essential key workers and healthcare staff. Next slide. And also at the start of medical school, we at the BMA are working, because you've got to start with equality from the day you start your career in medicine. And tragically, there are 4 times as many BME, there's a 4 times likelihood of being bullied and harassed if you are from a BAME background in medical school. I mean, that's tragic if that's your experience of the health service as you start training. And we've now launched a charter for medical schools to prevent racial harassment, and I'm very pleased that the vast majority of medical schools have now implemented that. Next slide. Now, equality does matter in the NHS. It matters, of course, because we have to be, it's right and it's fair for everyone to be treated equally. But actually, we know that it's best for patient care, that in providers that have equality and diversity at its heart, you have better patient outcomes. You have greater patient safety because healthcare staff are working in a more supportive environment. We know that organisations rooted in equality are more content. They have greater staff satisfaction, and you can improve and retain staff better. I've got to thank Yvonne for this. It was something she drilled into me when she was, at the head of RES, and so I learned the lesson, and it's absolutely what we should be doing. It's best for the taxpayer, because if you've got better patient outcomes, less medical error, that of course that's the right thing to do. So it does matter to all of us that we have race equality in the NHS. Final slide. So what we're calling for at the BMA is that the pandemic, the experience of this pandemic, has woken us up, and it does demand that we have to finally end the unacceptable long-standing inequalities in our health service. And that actually means not more reviews and the rhetoric around it, but you've got to go down and tackle the structural root causes. You have to address the workplace culture. The NHS needs a complete transformation of culture that stops discrimination of our BME healthcare workers. This isn't about tick box studies, and stats. It needs a cultural revolution, a culture where any doctor or healthcare worker can feel free to speak out without a fear of being disadvantaged in doing so, where in fact errors are celebrated as a way of learning to improve safety in the future. Our overseas doctors and nurses come and work here. They come here to save others' lives, and they come from around the globe, but they don't get the induction, support and mentorship. That has to change. The medical curriculum, we're calling for that to change to include the importance of diversity and equality from day one, adding to the racial harassment charter we have. We have to have senior accountability, and that accountability has to start from government right down to those leaders in providers, and they have to be assessed on performance on equality objectives. And that needs to be measured somehow. So we need standardized monitoring and reporting of racial disparities to see how well we're doing, like we do for every other NHS performance indicator. And that needs to be evaluated by a programme of policies, interventions, and actually disseminating best practice, because there is good practice going on. There are examples of where changes occurred, and let's make sure we learn from that and spread that good news and good practice across our health service. Finally, thank you. I think that is my final slide. My final slide is to thank you. Thank you so much for listening. If you want to know more about the BMA's work, go on our website, type in BME member forum and you'll see the work we're doing and work we want to continue doing. Thank you very much.
Chand, that was absolutely phenomenal. Thank you so much for that. Halfway through, I mean, I felt so emotional when you were talking about Dr. Tun, and you know, my heart goes out to him, his family and his friends, because that's a really tragic and dreadful story. And some of the things that you were saying, it brought back memories to me of a time back in, I don't know, 2013, when Sir Robert Francis did his review on mid-staffs. And some of the things that he was saying, he found inadvertently actually, was that Black and ethnic minority staff would not speak out. They wouldn't speak out for fear of what would happen for them. And of course, that then impacts on patient care, because if you are not able to speak out, consequently, the issues might be about patients, and that might be very, very difficult for patients. But we have to start making the changes. People wanted to know a couple of things from you, Chand, about collecting data. Are we collecting ethnicity data now? Because I know that we weren't. Are we doing that now routinely?
No, and I'm really hoping that the Race Observatory will be calling for really good metrics, because, for example, the data we should have been collecting back in April. In fact, I did call for this data. Would have told us whether the impact on BME healthcare workers was because of the jobs role they had, whether it was exposure to the virus, whether they had the right PP or not. So I think moving forward, this is something that's so important. Without that information, we won't be able to tackle the root causes. So the short answer is we've not reached that position. There is more data. We've got ethnicity now recorded on death certificates. We finally have ethnicity recorded in terms of vaccinations. But no, that's something we need to do at the Race Observatory, Yvonne.
We need to push for that. Somebody else has asked about the policies, because we have policies and processes in place around risk assessment. How do you make them real? You know, how do we stop them from being a tick box exercise where somebody goes in and says, well, are you protected? And you say, well, yeah, I think so. And they tick the box and say, well, you've had your risk assessment. Thank you and goodbye. How do we make this real for people?
I think this is what I was talking about, a real cultural transformation. So the leaders, those managers, those people who are employers need to really, from their hearts, understand this is about protecting hardworking, dedicated staff who really should not have to come in harm's way in the course of their duty. Now, if that is your real belief and you really stand by that, and that's what real leadership should be about, yes, you won't make it a tick box exercise. But if your aim is to make sure you hit the target required of you by NHS England saying you must do risk assessments, you won't get it right. I think that this is the cultural revolution we need in our health service, a real compassionate leadership, understanding the value of equality, but also the value of protecting staff.
Chand, as always, inspirational, professional and wonderful. Thank you so much. Really appreciate it. And without further ado, we go to the lovely Dame Donna Kinnair. Donna is now going to talk about exactly the same thing, but from a nursing perspective. So Donna, over to you. Thank you.
Thank you. Sorry, I was just trying to come off mute. You've heard that all the way through the pandemic. So good evening, everyone, and thank you for inviting me to speak to you. I'm really pleased to have the opportunity to engage with you alongside my fellow speakers. I'd like to start by introducing myself, and Yvonne's already done that, but I am the Chief Exec and General Secretary of the Royal College. And I'm speaking to you today, not just as the largest union and professional body for nurses, but also I will bring in some of my lived experience through COVID. But we represent about 450 to 470,000 members that are working as nurses and midwives and nursing support workers, nursing students, nursing associate, nursing apprentices. And we work in all settings, all across nursing specialisms. And I just want to say how important it is for us to give ourselves time to have these conversations, because we're all under pressure and we're all stretched. So I really want to thank everybody for making the time to join us today. And I want to start really, when we talk about the COVID-19 pandemic and the impact on nursing staff, it must have been near on a year ago that I was probably April 20. I'm sitting in my office and I take a phone call from a nurse out there who's saying, I'm really concerned, Donna. I'm working with a whole range of undifferentiated patients. Everybody else in my team, i.e. all the other people, and other meaning people that weren't from the BAME community, were working from home, tucked away at home. And yet I'm sent out to give the depot injections to this undifferentiated group. And at the same time, she said, I've gone to my director of nursing and I've just asked her for an apron, some masks and some gloves, and I've been denied it. And you sort of say, well, are you sure about that? Can you just go back and ask again? So we're in email dialogue, telephoning. This has been denied each and every time, and yet we're looking across and we're watching GPs get PPE and close their surgeries for undifferentiated patients, and yet you're having to work in an environment in a mental health trust without anything whatsoever. Just wash your hands and carry on doing what you're doing. And this went on and on until I actually said to the individual, I'm sure, honey, they need you more than you need them. Because if you're not there to do it, that director of nursing will have to come down and give those injections herself. So the next time you see her, you demand it, or you ask her to come and go and give the injections. And I just wanted to say that all the issues that Chand explained equally applies to nursing. From the time you step in to be a nurse, right the way through your career. And it wasn't too long ago, just before the outbreak of this pandemic, that we were talking Brexit and reducing immigration numbers and actually not wanting people to pay for their healthcare despite themselves providing it, you know, costing thousands as a benefit for coming from your country to work in our health service. So the pandemic has really showcased the best of nursing, and it has promoted our profession in the public consciousness, both, you know, all healthcare workers actually, not just nursing. It has demonstrated our dedication to patient care, our skills in the profession, and the way in which we have to make complex decisions to treat and diagnose our patients, and where we work in terms of just battling against this in research, innovation, and making sure that we're practicing. But also what it has demonstrated is the way that nursing is actually fundamental to patient safety, and how much the power of the nursing voice, the most trusted profession, is when we're speaking out and advocating on behalf of our patients. It's really interesting because what I say and what I will take away from this pandemic is no longer do I have silly people asking me, what does a nurse really do, Donna? Because there's so many of you. I mean, I can't see, you can jolly well see it now. And to be honest, as the pressure of the pandemic has continued, we have become under more and more pressure, working harder than ever before. We contend with the fact that, you know, the ONS latest data said 886 roughly healthcare workers have died in the year, and we're under more and more pressure. We're exhausted, we're overworked, and also we feel to some extent undervalued and not heard. If you think about the sacrifices right across the healthcare spectrum people have made, moving into hotels, leaving their families, and we are caring for more and more patients than we ever were. If you think about just the admissions into hospital, the amount of sickness that we've been dealing with. And we entered this pandemic with 40,000 nurses. There was 50,000 across the vacancies across the UK. So we all know that we started it ill prepared, whatever profession you were in. And we know that when you've got that, even if you bring people out of retirement, which you might well have needed to do, even if you cancel students, we all know that everybody is going to be overstretched. And even though thousands of nurses came back to work out of retirement, even though we pulled our students off, there still wasn't enough to cope with some of the issues that we were finding. And if you think about the 100,000 vacancies just in the social care sector, we know that much of nursing staff have had to go over and above. Many of them have picked up extra shifts. We've been redeployed to critical care units outside of our specialism. We have demonstrated that we have been in there and the ongoing demands of the pandemic and the ongoing staffing shortage have meant that the stress, the workloads and the concerns about whether the care is being delivered safely and effectively. And in all this, some of the responses from those around us have been a bit mealy-mouthed. We've seen so many letters saying, we know you're under pressure, we probably won't be as hard on you at the Nursing and Midwifery Council. So it has led to a lot of self-isolation, lots of sickness, and actually I believe some of the inadequacy of the protection has meant that we too have been picking up the virus like Topsy, and particularly the 70% more infectious virus. We are also becoming unwell, we're watching our families become unwell, and we have been under this strain like everyone else. And I speak to nursing staff regularly, and I want to say, now, at the first wave, I actually got off and went and volunteered at the Nightingale. And I just want to tell you a bit about the impact on me, because I went into the Nightingale and a friend of mine said, Donna, when you get down to the floor, you will be shocked. And I remember thinking, you know, clearly you don't know me. I'm an age-old nurse, been around for a long time, did ITU in my time. Had gone through the revalidation and CPDs on ITU. Sorry, there's lots of traffic outside. And actually, when I got down to the floor, I was shocked, because there were 40 patients in the Nightingale that day. 39 of them were from the BAME community. You know, when you walk into somewhere and you think, actually, I can't believe this. You know, I actually saw black African. I can see why we can say that it was 4 times more likely they were 4 times more likely to be infected, and if you were Asian, it was 3 times more likely. I just kept looking at them thinking, God, this could be my family. This could be somebody I know. So, and I speak to nursing staff regularly. I've been out again looking at the impact of long COVID, and we know that we've been left in a situation where we're continuing without any fuel in our tanks. Our resilience is being really tested. For me at the RCN, our counselling service has doubled its service to meet the demand. We've had to extend our hotline in the same way that Chand has, because people were ringing us wanting to know what they could do when they were being denied PPE in the middle of the night, for instance. We know that there were equally more patients with COVID outside of ITU, and yet people were still being denied proper access to PPE. And some of our surveys, if you can just turn to slide 2, this is how people were feeling of May last year, and this was just during the first wave of the pandemic. The percentage of people, we asked our members last year across the NHS and independent sectors how their professional lives have been changed since the pandemic, and it made for sobering reading. 36% were thinking of leaving the profession. Now, we know that that might not be the final figure, because actually we know there's a hero effect and more people will join up. But what you then lose is the experience, and that was up 27% from the year before. Now that was at the end of the first spike, so can you imagine how people are feeling now? And 61% said pay was a factor. Many of them told us that they felt overworked, undervalued and overstretched. And the ongoing research with some of our members felt that if you came from the BAME community, you were much more likely to be, the perception was, you were much more likely to be denied PPE. So many of these factors were pushing them to breaking point. And I wonder if we, you know, in slide 3, if you can just turn it to slide 3, we did some more in-depth research, and we're doing that at the moment. And while I can't share the complete findings, we know that our members continue to feel undervalued. Morale is a serious issue. Pay continues to contribute to that feeling of undervalue, and there are ongoing issues of discrimination in the workplace, and a lack of progression continues and opportunities. I mean, I have to say that it was really interesting, because it was the question time I did almost a year ago now, that Matt Hancock promised us stats on the death of nurses and healthcare workers, and I believe they have them, but they are very reluctant to share them with us. So as a body, as a trade union, as a professional body, we've got a clear role in supporting our members and the wider profession from the very beginning of the pandemic right the way through. And we are here to advocate on behalf of our members, protect their rights and provide support and guidance to them. Now, just even on some of the things that Chand was talking about, we've been calling on employers and governments to make sure that they protect staff even with the new variant. And we're saying that staff safety must be prioritised. But even after we did the work on risk assessments, the first thing we heard was that practices were turning nurses away because they were considered to be vulnerable and not worthy of working during the pandemic. So actually they just thought, well, we'll just sack you. And we had to go into battle. That's some of the NHS when people, so they allowed them to work all through the first part of the pandemic. And suddenly when they had to risk assess them and they could identify that these individuals had high blood pressure or other conditions, they decided it was time to terminate their employment rights. And that was in some of our primary care elements, and we had to go to war on that. So we are demanding at this moment in time an in-depth review of infection prevention and control guidance and the ventilation in healthcare settings, because for us it seems if we've got a 70% more aggressive, more infectious variant of the virus, have we got the right protection? And we know that throughout this whole pandemic that we've always been one step behind in stepping up to provide adequate PPE for our nurses and doctors. So preventing the spread of COVID-19 does require good infection prevention and control measures, and that includes hand hygiene, changing gloves, but also we do know, even from some of the adverts that the government, is that the aerosols that are being sprayed out there, the surgical mask that we are putting most of our care staff in does not provide adequate protection. So we are asking for staff to be given a higher level of respiratory protection to protect against airborne spread. We know that a lot of the research has demonstrated this. We first wrote to the government about this last year, and there's been a wall of silence on this, which has led to almost a post-COVID lottery in terms of provision. So because some trusts have recognised it and offered their staff a higher level of protection. But we really want full confidence for all our staff, given the impact it's had on many of our communities. And we recognise that employers have to ensure that it's a proper supply of the right equipment. So it's made clear to me that we are a safety critical profession, and a role that we've taken up that role of COVID-19 vaccination, which has been central. Nurses have been central to that programme. Alongside other colleagues, we've managed and we've overseen the logistics and practicalities of this programme. And we've also worked hard to provide local solutions for communities. So whether it's going into homes, whether it's helping to educate and counter the misinformation that our communities are receiving. Now, for those of you, I mean, I'm on a family WhatsApp because I have a multinational family, a global family, we like to think. But if I could share with you some of the videos that are spreading this misinformation across the sectors, various groups, that, you know, some of this misinformation goes to the very heart of our beliefs, such as infertility, making it seem as though it's particularly for us. And unfortunately, we are absolutely trying to ensure that when people consider taking the vaccine, it's about informed consent. But actually, the anti-vaxxers have been at this game. Many of the emails and you know, just little films that I've had have been on my phone coming through since last year, and sometimes led by medical professionals. So it's important for us as healthcare professionals that we give people informed consent, and we recognise that having the vaccine will protect us from really serious illness and also them. We don't need to be the people that say, actually, you have to have it, because it is about making sure that individuals are given the information and that it is an individual choice. I do not wish people to be forced or coerced into having it. Can I just show slide 4? I just want to share with you the most recent survey of our members, and we published that on Tuesday of this week about the COVID-19 vaccine. And you can almost see from that that the following slides will show the survey. We found, if you look at slide 5, 85% of nursing staff have had at least one dose of COVID-19 vaccine. Almost 4 in 5 respondents require the second dose, because only 7% had received both doses. The survey found that nursing staff in the wider health and social care community, social care or employed by agencies, are the ones that feel or have been left behind in the vaccine programme, and they are the biggest risk. So if you work for an agency, you're least likely to have had that vaccine. Only 71% of non-NHS staff had received one vaccine compared to 91% of nursing staff working in the NHS. So of those, slide 6, if you can just show slide 6, of those nursing staff who had not yet received a vaccine, we asked whether they'd been offered it and where they were. 70% of those who haven't yet been offered the vaccine worked outside of the NHS, and this compared to 35% of NHS staff. If we look at the employment status, 80% of agency staff who hadn't had their vaccine had not even been offered one, and 70%, that's slide 7, 70% of temporary staff and 66% of bank staff were also in a similar position. So this really compared with 47% of permanent staff who had neither received the vaccine nor had been offered it. So as UK hospitals and all hospitals increasingly rely on agency and temporary staff to overcome the permanent staffing shortages, the findings for us as the Royal College of Nursing are really concerning. And that's especially for those working in communities, care homes and people's own homes, because actually we know that a high percentage of them will come from agency staff, and they are caring for the most vulnerable in our society. So as we've approached the government deadline for vaccinating the top 4 priority groups, we're calling to the government to redouble its efforts in order to reach those working outside of the NHS or as agency or in temporary positions. And we did this when I met the Naheem Zahawi, the Parliamentary Under-Secretary for State for COVID-19 last week, and we raised these concerns that actually it's not just the NHS, but it's from the wider health and social care system and the ability to access the vaccine easily. So he's actually promised to look into this, and we're going to continue to monitor it. If I can just take you to slide 8. The rollout will continue at pace, but as it does, we know that there are growing concerns about how to address vaccine hesitancy in Black and minority ethnic communities. And I think it's important for us because those things that actually go to the heart of our community's beliefs and cultures, such as it will interfere with your fertility, all of those myths are things that are concerning and targeted on us, and they raise a lot of the videos I've seen. They raise the issue, they don't necessarily answer the question. They just sow that seed of doubt in our community's minds, and we have been slow to make sure that the information is in all languages. I mean, if you think about it, when you look at the transgenerational homes, it's the young people that are accessing social media, and it's the young people that are going to advise their elder relatives about the vaccine. So it has revealed a lot about how we put information out, and I know it's getting better, and there's lots of communities now making sure that it's in the right languages and it's reaching the right people. But COVID-19, there is no doubt about it. It has really revealed a huge amount about inequalities and the wider structural disadvantage. And ethnicity continues to be a major factor in health outcomes for communities during this second wave of the pandemic. and it does impact on us. So we recognise these inequalities, but unequal housing, insecure employment, and the real issue about how we can promote or increase access in healthcare, because it's open to everyone, but not everybody can get in. And seriously, I mean, it's been as long as my arm. I saw this working as a health visitor in my early career, and I've continued to see the impact of poverty and disadvantage on so many patients and communities throughout my whole career. So I'm really pleased to be working with the Race and Health Observatory, because actually, if we don't pressure them to say, well, how many of us are dying, they can bury that. We need to have some of that pressure. Why is it that, we've got worse outcomes for amputees in some of our BAME communities? There are deep-rooted concerns, not just for us as healthcare staff, but for the communities that we work with. And so the huge amount of mistrust that we're seeing around lack of access, questioning the COVID-19 vaccine, or even the refusal to have the vaccine. I was talking to an individual that wrote into me and just, was at risk really of developing a fatalistic view, having read some of the things that she had read, looked at the historical issues. But like I said to her, you can be a fatalist, but we can't actually fight disadvantage if we're all dead. So I'm encouraging people to actually take the vaccine. The anti-vaxxers have been so quick to play on our fears and our suspicions, spreading myths. And, actually some of the ones that I've seen are actually doctors coming out and saying that they've got to protect us from taking this vaccine, from this huge experiment. So I'm not surprised that we feel a deep level of mistrust, but actually one of the things that we need to be doing as clinical leaders is getting out there and busting those myths, as we've seen being done today. I think it's important for us to have those conversations with our patients, with our communities. Listen, I'm having them all the time with my family. It's not about dismissing their thoughts or their beliefs, but to engage in a conversation that explores that and providing the evidence to combat some of those misconceptions. I think it is about being honest. It's the best way to address these concerns. And our community staff and others have an important role to play. I mean, one of the things that I just want to say, and why it's so important to penetrate families, is I was talking to a former colleague of mine, and he really told me how health teams are working with local community leaders, but actually had just come out of a home as a GP, and he said, I went into that home and they were treating a COVID patient with aloe vera and sea salts. It doesn't cut it. The patient ended up with, not making it, and with a GSC score of 5. So there's lots to be done. Local MPs are working on this. We all have a part to play. And actually, it's not just about, the rhetoric of taking pictures of ourselves, but having that honest conversation. And I'm happy as a nurse that the only way that we can actually convince people is understanding their fears and working with them, because we know that the take up in vaccine is the only thing that we can see at this moment that we have that helps us to see our way out of this pandemic. So I know, as Yvonne started this, when she said the virus, as people say, the virus doesn't discriminate, but it does. It has done. It's not just about us. It's our collective responsibility of healthcare and nursing staff to do everything we can to promote the protection of those around us, to act as role models. It is our collective responsibility. So I'm going to be having my vaccine as soon as I'm invited. That tells you how young I am. And I'm just, I think, here to answer questions. Just slide 9, I just wanted to show you my last slide. That actually is, thank you for inviting me for speaking about COVID-19. And I think that we've got to make further opportunities to come together as healthcare professionals and address the challenges that face our communities, because actually the challenges aren't just today in COVID-19. Those challenges will be we'll be facing them for years ahead. I've faced them all my career. They're not going to stop suddenly. But I'm hoping that the work of the Race and Health Observatory will help us face those challenges with the data, so that actually we're able to challenge it and actually do something about where it's going. So thank you for listening to me.
Oh, thank you. I mean, if you hadn't said you clapping, so I'm going to clap you anyway, because that was brilliant, Donna. And it really was. As a nurse myself, I could feel a lot of what you were saying, not just here. I could actually feel it. And the thing that you said about bank staff particularly, and nurses that are outside of the NHS and actually working in care homes and so on, and us having to protect them as well, because we know that the majority of those people happen to be from Black, Asian and minority ethnic backgrounds. I'm working in an organisation at the moment where there are many more people on the bank and agency from Black and ethnic minority backgrounds than they are in substantive posts within the organisation. And if we're already saying that those people are not are not protected or not taking the protection, then we really need to do something and up our game. I've got some questions for you, Donna, very quickly. People want to know whether the Royal College of Nursing are doing the same thing as the BMA and arranging a national forum for its Asian and minority ethnic staff at this time.
So we are arranging, one of the forums that we're arranging is predominantly based on BAME overseas nurses that have come in to work in the organisation, and actually we hope that other nurses from here will join that, for other BAME nurses, because we know that those particular individuals, now I can't tell you how many hundreds of nurses have been flown in from India or Africa throughout this pandemic even. You know, and we don't see them, but they're there flying in because we know that the government has a massive target to keep. Some of the stories that we have heard from those overseas nurses are experiencing things that actually we as British born and bred and grown up here wouldn't tolerate and couldn't tolerate. But actually we have to help them navigate it. So we are setting up networks. We've already had 2 or 3 meetings with them, and we will be inviting Black British, African and Caribbean nurses to join that as well.
I'm going to have to cut you there because I'm already being a terrible chair and not sticking to time, but thank you so much for that. Everything that you said resonated, and I really value and appreciate everything that you're doing for nurses, nursing, and for all of your friends and family. Thank you so much, Dame Donna. Really appreciate you being here tonight. Thank you. And without further ado, I'm going to move us on very quickly to Professor Jackie Dunkley-Bent. Jackie.
Thank you, Yvonne. I'll go on to my first slide. Can I just say what an absolute privilege it is to be at the inaugural event of the Health and Race Observatory, and it's really reassuring to know that at pace you are all in this space. So I'm going to focus a little bit, in fact, entirely on pregnancy and COVID, naturally within the context of Black, Asian and minority ethnic people, women and people. So just to set a little bit of context, if I may, we know that there is clear evidence that certain Black, Asian and minority ethnic groups have a higher rate of infection in relation to COVID, in relation to the coronavirus, and higher rates of serious disease, morbidity and mortality, and we know this to be the case. If we move into the, still on the first slide, thank you. If we move into the COVID space, we have data from the United Kingdom obstetric surveillance study that so still on the title slide, thank you. So we have data from the UKOS, the United Kingdom obstetric surveillance study, that that considered the outcomes of pregnant women and their babies admitted to hospital in the UK between the 1st of March and the 14th of April. So I'm now talking about pregnant women, whether you're a healthcare worker or not. I'm talking about pregnant women. And so UKOS considered the outcomes from COVID on pregnant women. And what they found was pregnant women were, I'm speaking in the past, were at no greater risk of severe illness from COVID-19 than the non-pregnant population. However, the incidence of admission to hospital varied according to ethnicity, age and BMI. And just to put that into context further, 55% of pregnant women admitted to hospital with coronavirus were from a Black, Asian and minority ethnic background. Just looking at that a little bit closer, Black pregnant women are 8 times more likely to be admitted to hospital. Asian women, pregnant women, 4 times more likely to be admitted to hospital. And just taking this, looking at this a little bit closer, if we look at data from Embrace, that's mother and baby, reducing risk through audit and confidential inquiry, the rapid review that Embrace undertook of the 10 women who died with COVID-19 diagnoses, 8 died as a result of the disease. 7 of those 8 were from a Black, Asian and minority ethnic background. So taking the vaccine really needs some serious consideration, because there's something about benefit and risk that needs to be considered. And as Yvonne said right at the start of this webinar, there is something about making informed decisions that are based on credible evidence. So on to the next slide. Thank you. So we know that the Joint Committee for Vaccination and Immunisation has advised that the Pfizer-BioNTech or AstraZeneca COVID-19 vaccines can be offered during pregnancy, but it can be offered to those who are who have a risk of exposure to severe acute respiratory syndrome coronavirus 2 infection, where the infection is high and cannot be avoided. So where the exposure is high and cannot be avoided. And that means that many of our healthcare professionals working in areas where there is a high risk of exposure, then the JCVI advises that that vaccine can be offered to pregnant women who are in that category. In addition, where a woman has an underlying condition that puts her at a very high risk of serious complications of COVID-19, frequently referred to as women in the extremely clinical vulnerable category, and that is pregnant woman with a cardiac anomaly, heart anomaly, they too should be offered the vaccination, one or either of the vaccinations. So in these circumstances, clinicians, so midwives, obstetricians, physicians, general practitioners should discuss the risks and benefits of the vaccination with the woman, so that the woman can make an informed choice, and that woman might be a health professional or indeed a member of the general population. And so the vaccines, and it's important to emphasise this, the vaccines have not yet been tested in pregnancy. So until more information is available, those who are pregnant should not routinely be given the vaccine or offered the vaccine. There are just 2 exceptions, and I've just described those. So if we move on to the next slide, and I'm going to just talk through some of the myths that are circulating. So Yvonne has alluded to some of the myths, and Dame Donna too has alluded to some of the myths. I'm going to really focus in now on pregnancy, in the pregnancy space, and in terms of myth busting. So frequently I hear, as the Chief Midwifery Officer, my baby will be affected or infected if I have the vaccine. So there's a fear that if you have the vaccine, baby will be infected. So the response to that is there is no known risk associated with giving a non-live vaccine during pregnancy. These vaccines, whichever one you have, cannot replicate, so they cannot cause infection in either the woman, in you if you're a woman who is pregnant, or your unborn child. Another concern that I frequently hear is it's far too risky to have the vaccine. I don't want to put me or my unborn baby at risk. And so my response to that is, based on what we know about this kind of vaccine, we don't have any specific reason to believe that there will be specific risks that would outweigh the benefits of vaccination for pregnant women. Another frequently recurring myth, concern, is relates to that there is routine pregnancy tests before the vaccine is taken, so that there needs to be a routine pregnancy test before the vaccine is taken. And I can inform you now in response to that concern that there needs to be a routine pregnancy test before the vaccine is taken. The JCVI has advised that routine pregnancy testing before receipt of a vaccination is not recommended or needed. Those who are trying to become pregnant do not need to avoid a pregnancy after vaccination. So just busting a few myths in that regard in terms of routine pregnancy testing, and also the worry from many if they become pregnant, that there is no risk, no known risk. Another myth, all pregnant women should have the COVID-19 vaccines, vaccine singular. And my response to that is, although the available evidence or the available data doesn't indicate any safety concerns or harm to pregnancy, there is insufficient evidence to recommend routine use of COVID-19 vaccines during pregnancy. So the recommendation is not for routine use. It is for those that I mentioned on my first slide, who are those who are extremely clinically vulnerable, or those who are in areas where there is high risk of the virus exposure. So the last myth that I'm going to mention is the vaccine will cause sterilisation. And I can reliably say that COVID-19 vaccine does not result in sterilisation or does not trigger an infertility response. And so I just wanted to really work through those myths and just provide some reassurance in that regard. Moving on to the next slide, I'm going to focus on the breastfeeding space now. And that there are some concerns about breastfeeding and the vaccination, and many myths about that too, real myths, because these are real concerns and fears and anxieties that we need to take seriously. So I can say to you that there is no known risk associated with giving non-live vaccines whilst breastfeeding. And again, going to the organisation that is driving what we do in practice, the JCVI, they advise that breastfeeding women may be offered the vaccination either with the Pfizer vaccine or the AstraZeneca vaccine, and there has been no known risk associated thus far. It's important to emphasise, however, that advice and guidance to make an informed choice is absolutely paramount, and it's important to consider that the health benefits of breastfeeding, along with women's clinical need for immunisation against COVID-19 and information about the absence of safety data for the vaccine in breastfeeding, should be shared with women so that we can support anybody that's pregnant, whether they're a health professional or not, to make informed decisions. So I think that's really important. People need to go to credible sources to make informed decisions. And I'm just going to finish, that's my last slide, but I'm just going to finish with an action for all, I call it. An action for us, I think, in the health sector, health and social care sector, is we need to ensure that our communication is culturally competent and tailored to meet the needs of our communities, because there are, as my colleagues have said, there are many false postings, strange videos from non-reliable sources. So we need to ensure that our information is culturally competent. In relation to actions for all, we also need to consider how we can reduce inequity in access for the vaccine, and also ensure that people are able to engage with health professionals, and there is some inequality there. So it's important that we as health professionals step into that space. From those who are listening who are from a non-health background, or even those who are from a health background, my ask to you is, can you consider the source of the information that you receive that is creating vaccine hesitancy? Can you consider the source? Think about, is it credible? Is it reliable? Do they have an authority? Do your research so that you can make an informed decision. And if you can access your GP in the maternity space, your maternity team, your midwife, your obstetrician, they are there for you. They are working tirelessly for anybody that's thinking about becoming pregnant, or indeed is pregnant, to help all those people make informed decisions. So I'll leave you with that action for all. Thank you.
Jackie, that was absolutely brilliant, and thank you so much for it, because I know that lots of women, lots of people in the NHS are of childbearing age, and unlike my good self who's gone past that many years ago, and they are concerned about taking the vaccine and potentially what might happen in years to come. For example, you know, how do we know this vaccine is going to be safe? How do we know it's not going to affect our fertility? How do we know that it's not going to affect any baby that we have in future? And then, you know, you've debunked a lot of those myths, and I really do thank you for it. Your presentation was on point as always, but also very carefully considered, and I think that people heard exactly what you had to say, and I feel like I do, much more secure in the knowledge that you've given us. So thank you so much for that, Jackie. So thank you so much for coming. I'm going to change the order around a bit now, because we were going to have Dr. Habib Naqvi, but instead, because we're running a tiny bit late, I am going to be welcoming Professor Kevin Fenton. Kevin needs no introduction. He's the poster boy, I think, along with Chand, of the pandemic, as far as a lot of people are concerned. So without further ado, Kevin, thank you so much.
Thank you very much, and good evening, everyone. It is such a pleasure to be here with you this evening. I'm going to actually project my slides, if possible. So I'm going to ask colleagues if you'll allow me to do that for this session. Thank you. And hopefully you'll be able to see this now, but I wanted to just begin by thanking the organisers for the event this evening, and both the depth at which we have explored many issues related to COVID, the pandemic, and how we've been able to answer and address head-on many of the concerns that members of the community have or professional colleagues have. And these issues are so important for us to speak openly about, speak authentically and honestly about, in order to get to a better place. So today, in the time that I have available, and I know we have limited amount of time today, I thought I'd focus not only on the theory of why things are happening as far as vaccine hesitancy is concerned, but to give a very concrete example about work that we're doing in London to address this situation, and how we need to work together across a range of partners with communities to again address this issue head on. And I think a key issue that we're learning as we're embarking upon this journey across the city, as we have an ambition to vaccinate more than 1.5 million Londoners before the 14th of February, is that we are keen that as we are implementing in the first 4 cohorts, which are the priority cohorts now, that we're learning the lessons of implementation, that we're learning the lessons of addressing inequalities, and that we're learning the lessons of using data in order to improve our implementation. So for those of you who don't know me, I'm the Public Health England Regional Director for London, and I've been in this role now for just under a year. I started the role in April of last year when we were almost at our epidemic peak in the city at that time. So on my first day on the job, we were really faced with hundreds of people dying in hospitals across the city at a time when we were into lockdown and we had to focus on controlling the pandemic. Over the course of the year, as many of you may be aware, I've done work on understanding inequalities as it relates to both the risk of acquiring COVID and having severe disease and death, but I have also focused on what do we do to address those inequalities and what practical steps we should be taking. And as the epidemic has evolved over the past year, we have seen different elements of the pandemic response being subjected to close scrutiny about why are we seeing inequalities and how do we refine our responses to address those inequalities. So at the beginning, as you heard from earlier speakers today, there were real concerns about inequalities in severity of disease and death from COVID. As testing became available in the summer, and then followed by a contact tracing program, there were real concerns about how testing was being offered, whether communities were taking up those testing opportunities, and how effective was contact tracing across different communities, whether did it vary by gender, did it vary by area of residence, did it vary by socioeconomic status or race ethnicity. Again, we've had to reflect on that, adjust our programs, and to ensure that we are addressing inequalities as we move forward. So the vaccine inequalities that we're seeing now are in fact unsurprising given what we've had to experience over the past year. And we have to view these inequalities in vaccine, both hesitancy and uptake within that context. So for this evening, I have only 2 slides that I wanted to review and to speak to. And the first really just encourages us when we are thinking about inequalities in vaccine uptake or vaccine hesitancy to take a systematic view of the problem. Vaccine hesitancy is not an individual's problem. It's not because individuals are choosing to be difficult or not to obey requests from the system, but they're often rooted in a number of social, cultural, interpersonal and institutional factors that unless we have that broader view and that broader understanding of the factors which are driving hesitancy and poor uptake, then we will fail to address them effectively. Similarly, the strategies which are required to effectively address vaccine hesitancy and uptake not only rest with the individual and the local communities, but a large part rests with the institutions which are set up to serve those communities. And there are things that at each step of the process, from helping people to reframe how they think and feel about vaccines, organizations have a role to play to motivate people to take up the vaccines, but also organizations have a role to play in addressing many of the practical aspects of vaccine access and uptake in order to get to a place where communities are vaccinated. So in London, we're taking this pathway approach to really understand the factors leading up to vaccine hesitancy and poor uptake. And again, this builds upon a lot of the conversations that we've been and the discussions that we've been listening to this evening. So if you focus on the upper half of this slide, which focuses on some of the factors which affect the likelihood of an individual to vaccinate, factors which really influence how people feel. And certainly for our communities, historic, political, sociocultural context is really important. People's knowledge and information about vaccination, people's past experiences about vaccines, and of course, going to health services and their experiences of engaging with health services will influence their trust and their willingness to take up these services in the future. People's risk of perception and trust, as well as what they perceive as being norms for their communities, will be
I'm just working at the moment.
A key part of it. I think somebody's not on.
Yeah, I just
and so these are factors which are going to be really critical in influencing how people feel about vaccination. We clearly have to think about the interpersonal factors, health literacy, language literacy, health beliefs, peer views, and of course parenting and guardian views. And as you heard, especially in communities which are living in multi-generational households, we are seeing increasingly that effect of younger people influencing how the attitudes and hesitancy within their older relatives within that household. So again, those interpersonal factors are important. And then as we think about some of the factors that institutions can bring to this, one of the things we're really keen to look at, certainly in London and I know across the country as the program's being implemented, are the things that we do to motivate vaccination, not only providing culturally competent and language competent materials, but ensuring that we're using the channels and the spokespeople which really resonate with those communities, really understanding where myths are being spread and ensuring that the facts, trusted voices are there as well. So within social media or looking at other channels where information is being shared. And the role of trusted health professionals is really critical. And you can see, I think now more than ever, I'm seeing far more Black, Asian and minority ethnic professionals of all backgrounds, whether on social media or on the television, speaking about these issues. And I hope that this is truly the beginning of a diversification of the images of health professionals that we're seeing in our country. And then finally, there's some practical issues that we've had to learn to grapple with when it comes to vaccine implementation. And as we've been scaling up the program in London, really looking at variations across ethnic groups and who's registered with general practitioners and how people are on the eligible list for vaccines, thinking about data and the shortfalls of data to really track who's getting vaccinated, who's being contacted, and how you follow them up. And of course, setting up effective call-recall systems so that even if people refuse the first or second time, they need to be given time to think about what they want to do and how to make that decision in their own time. And clearly, the policy within which this all sits is critical as well. So we've taken this framework in London and we're applying at a London level a major regional strategy to tackle hesitancy. And we're not just looking here at Black, Asian and minority ethnic communities, but we're looking at all the domains of inequalities of vaccine access in the city, because we know access is higher if you live in less deprived parts of the city than if you live in the more deprived parts of the city. And we clearly see differences in uptake now across racial and ethnic groups, with Black African and Black Caribbean groups being significantly less likely to have their vaccine and reporting high levels of hesitancy. So very briefly, in London, we really want to ensure that as a city, as boroughs, as communities, we are having one conversation about the importance of vaccination, and we're engaging multiple channels, hearing from our communities about their concerns, speaking to communities and community members, and having authentic conversations about what this means, why this is a tool for ending the epidemic, hearing concerns and using the facts, using the evidence, using the data to respond to those concerns. So we're doing this in order to be more than the sum of parts across the city and ensuring that we're coordinated, and at every level in our city, we're having conversations about the vaccines. We have a number of objectives which are highlighted on the slide: better coordination, enhancing national messages, ensuring that we're building upon local insights and using data to help us to address the issue much more effectively. And of course, ensuring that we're sharing much more diverse and inclusive materials and messages and communication channels in engaging our communities. Our strategy in London has 5 key pillars, which are highlighted on the right of the slide, and they really relate to how we coordinate more effectively, working in partnership with our faith and community organisations across the city to ensure we have a single engagement plan, we have a common delivery plan, and where appropriate, we're encouraging all of our partners to share materials as they're being developed. If we have a Somali community in Ealing and we're developing resources there, we should be able to use that across the city and indeed nationally. So we want to get much better at sharing our materials. Second, we want to ensure we're doing much better on data, intelligence and evaluation. We know that if we understand where there are gaps in vaccination and where exactly the communities and where those communities are, we can do a much better job of outreach, of engagement, of local mobilization, working in partnership with local authorities. And so we have been building and working with our NHS partners to think about how we use data across the city much more effectively. Third, we're activating partnerships and really looking beyond traditional healthcare partners to really help us to think about promoting not only the vaccination, but encouraging greater engagement on testing, contact tracing, and prevention for COVID, because this is truly going to be a key part of exiting the pandemic. And we've developed fantastic partnerships with our faith communities, with the voluntary sector communities, both at the local level as well as the regional level, to amplify messages around the pandemic. Fourth, we're doing a lot of really good work now on maximizing the use of engagement resources. And this is critical because time is of essence, resources are scarce, and we really want to ensure that we're not reinventing the wheel in every borough, in every conversation. And so by working together, we're organizing and sharing information and community resources. We're developing a trained cohort of individuals to begin talking about vaccine hesitancy, so that message is clear and consistent. And we're working with national colleagues on some of the national materials and ensuring that we're amplifying them across the city. And then finally, as we heard from other speakers tonight, really focusing on culturally competent assets, ensuring that there's language competency, appropriate reading ages, appropriate images which are being used, and creating a data bank of these resources so that we can pull upon them far more effectively as we address issues related to hesitancy. And putting all of these together for the city, I hope that not only will it help us with the first phase of the vaccine rollout, and we can see the benefits of it as we are progressing, but as we prepare for going to even younger age cohorts, where we may have more hesitancy in some groups, we will be having a much stronger foundation for addressing this issue. So, Yvonne, thank you so much. Tonight, I really wanted to go from the general to the specific. I wanted to reflect on what we do about inequalities, and I wanted to share a little bit about our approach in London, recognizing that really excellent work is being done across the country, both on vaccine hesitancy, but also addressing the inequalities that have arisen and have been highlighted by the COVID pandemic. Thank you so much.
Oh, thank you. Thank you so much, Kevin, for that. That was really, really inspiring. And one of the questions that has been coming through on the chat quite a lot, and I thought I'd save it for you, is that of trust. What people are saying is that, you know, how do we trust that this is going to be okay for us? And a lot of the hesitancy is around, you know, is it safe? What are your thoughts about how we can get communities to really believe that this is safe for them?
Yeah, that's such a great question. And as we're doing our community engagement events, this issue of trust keeps coming up. Now, I often think of trust as a function of being truthful, right? It's a function of being consistent, right? And it's also a function of time. You can't rush trust. You have to build it and you have to earn it. And you can only do it when you're speaking the truth and being honest and speaking from a place of authenticity on what we know, what we don't know, and what the sort of areas of further development and investigation are going to be. And in a lot of our conversations, even us saying as healthcare professionals, this is what we know from the data, here's how we can reassure you. But where there are uncertainties, here's what we're doing, whether through research or whether through further evaluations to help to close those gaps. And I'm finding it's about having those consistent conversations with communities as well. But we must remember that mistrust is often on the back of historic difficulties that people have with the services that we also need to overcome as well. And then finally, Yvonne, what I'm hoping is that the conversations that we're having now shouldn't just be about the vaccine, right? We're setting up an infrastructure for the ways in which we engage with our communities to build trust for the vaccine, and I hope for other challenges that we'll have ahead with this pandemic and other health conditions.
That's brilliant. Thank you so much, Kevin. Really, really appreciate it. I know how very, very busy you are, so it is our joy and pleasure that you were here tonight. So thank you so much for that. I think time is really pressing now, but before we finish, I would be really amiss if I didn't introduce Habib. Dr. Habib Naqvi is the director of the Race and Health Observatory, and he wants to have a few words with you before we wind up and say goodnight. So Habib, over to you.
Great. Thank you so much, Yvonne. This is the Race and Health Observatory's first event, an extremely important and timely one. And as the speakers have said, COVID-19 has affected people in so many different ways. And the fact is that we cannot escape the reality of the 115,000 deaths in the UK since the start of the pandemic. But what we can do is learn the lessons from the previous waves and what's happening right now, and draw insight from the evidence on how the virus is impacting our diverse communities, just as the speakers have highlighted this evening. And that has become one of the key priorities for the observatory as we are setting it up. And we have begun to work on 5 different areas within the observatory, including an area which is called protecting the vulnerable. And within that, the immediate priority is to focus on COVID-19, and we're doing that in a number of different ways, including working with the London School of Hygiene and Tropical Medicine and the RCN and Public Health England, looking at the impact of vaccine uptake amongst Black and minority ethnic frontline staff in health and care, and also looking at the impact of the virus and looking at vaccine uptake amongst our communities. And I'm pleased to say that this evening we've launched a infographic which Owen will drop the URL in the chat box for, and it is designed to present sort of key recommendations to our leaders within healthcare and within community organisations on how they can maximise vaccine uptake amongst Black and minority ethnic staff. Within the observatory, we also have a world-class expert and brilliant board led by Marie Gabriel, and including some of the speakers that you've heard this evening. So Chand, Dame Donna, Jackie, who's leading on the maternity work. Thank you so much for your excellent speeches this evening. And finally, before I hand back to you, Yvonne, thank you to my wonderful team that organised this webinar in record time. Back to you, Yvonne.
Thank you so much for that, Habib. I'm just going to be winding up very quickly, but I just want to say a huge thank you to you, Habib, for giving me the opportunity to host this wonderful inaugural event, but to Dr. Malheur, who talked to us about the virus itself and how it manifests itself and what it does. We then had Chand and Donna talking about the virus and vaccine from a nursing and doctor perspective, and it was just wonderful to hear what they had to say, though some of it was incredibly disturbing, and I think I will continue to think about Dr. Tun for a very, very, very long time. And then Jackie, who came on and debunked some of the myths, and I thought it was brilliant that she was able to do that about pregnancy, women having babies and so on. And finally, we had Kevin talking about an overview, a strategic approach to managing the virus and managing to get people to take the vaccine. And as I said earlier, this is not about making people take the vaccine, it's about giving people information. And I've been keeping an eye on Twitter this evening, and I can see that people have really valued the input from our wonderful and amazing speakers. So thank you all again. But before you leave, at the very beginning, we tried to do a survey and it didn't work. And I am going to see if we can do something again. Are we going to try to attempt the word cloud at least to see whether or not people enjoyed this event? So what you need to do is to go back to your phones. Let's see if this works this time. You should actually, I think Donna's lining it up now. I think you should have Mentimeter in your phones now. What has to happen is that you have to put it over the QR code and click on it to get the survey up. And this one is a word cloud. So what we want you to do is to write 3 words into the boxes that you can see there and then press submit. And that will help us to see in real time whether or not you enjoyed the session, whether you want more of this type of session and how it's all going to work. So I'm seeing it happening now already. So people are beginning to, I think a lot of people have left, but if people can continue to do this, that we'll have a really fantastic word cloud. Let's see if it's happening. Yep. See, when technology works, it works really well. So people are actually doing a really good job here of bringing up the word cloud, and we've got fantastic words here. This is excellent, excellent, informative, inspiring, reassuring. Reassuring, that's a really good, that's a fantastic work. Professional, brilliant, factual. These are all words that I'm really enjoying reading. This is great, because actually in real time it's an evaluation of the event. It's giving us information about what works for you, what we need to think about doing in future, what we need to think about in terms of making sure that things stack up for every single one of our members of staff within the NHS and beyond, and making sure that we give you the information that you need, as well as working really hard to close down on those disparities, to close down on the health inequalities that have made things so very, very difficult for our Black, Asian and minority ethnic staff in our NHS at this time. And I'm delighted to be working with Habib and the colleagues on the board of the Observatory in order to be able to help move this agenda forward, and move this agenda forward we will. Look at that, that's absolutely brilliant. It's really, really good. And we've got 238 people who have been. It's superb. Thank you so much, everybody, and thank you for staying on an extra 5 minutes. I have to pat myself on the back and say that I'm not a bad. Oh look, there's another. Oh, the vaccine one. Oh my goodness, I forgot about that. I was just about to say good night. And there's something here about the vaccine. I have taken the vaccine. I'm going to take the vaccine. I am not, let me just put mine in as well, just to say, put mine up as well, to see who is going to take the vaccine. And there's still a couple of people who are not going to take the vaccine, but on the whole, people are going to take the vaccine. And somebody, there's 13 people who are still undecided, 15 people. The interesting thing about this is that when we started, the point was to actually have a survey at the very beginning and then have one at the end. But unfortunately, it wasn't working as well for me at the very beginning. But you know, it's a learning experience. But what I can see here is that lots of people have taken the vaccine. Many more are going to take the vaccine, and there's some that are still undecided. With the ones that are undecided, I would urge them to have conversations with people who have had the vaccine, and have conversations with people who understand and know what they're talking about. So from that perspective, I think it's been really good. So thank you all very much. Really appreciate your time, your energy, your commitment of being here at 7 o'clock at night. Have a good evening, keep safe, keep warm, and we hope to see you again soon. Take good care. Bye-bye.